Okay, we're going to have a discussion on thoracic endovascular aneurysm repair now and issues that could potentially be related to it. And Marvin Atkins, who's recently joined our faculty, will be leading that. Marvin, we're very pleased to have him on our faculty. Marvin is a board-certified vascular surgeon in practice for 10 years and decided that he wanted to be a cardiac surgeon as well, so he went and trained at Penn under Dr. Bavaria, and after he finished, we were lucky enough to have him join us. So he sort of brings the best of both worlds, and very happy to have you here. Thank you, Marvin.
Thank you, Maj. Yeah. So what I tried to do is ask everybody to put together a few cases of either difficult cases that you would have done something different, or something that you had tips or tricks that you thought that would be useful for the audience. So I have a couple cases here. In the interest of time, we'll skip the third one. So the first case, this is when I was working at a level 1 trauma center. So this is a 28-year-old gentleman, autopedestrian victim. It was a drug deal gone bad, and the buyers ran over him 4 different times with a vehicle. He had a CT scan in an outside facility, and I was called by one of the surgeons there who said, well, he's pretty stable. Had some brief episodes of hypotension. His summary of injuries there, traumatic aortic injury, hemothorax, large blunt liver injury, splenic injury, subarachnoid hemorrhage, traumatic brain injury, bad pulmonary contusion. So the guy was pretty messed up. The surgeon that called sounded that he was very concerned about the patient. So of course, I could tell that we actually brought the team up on the helicopter pad, knowing that this could be pretty hairy. And so of course, when they opened the doors of the helicopter, they've got 2 bags of blood that they're squeezing in. And they said they think his pressure is maybe about 40 systolic. So we rushed straight downstairs to the operating room, just basically splashed betadine on him, and then percutaneously stuck both femoral arteries, placed a 20 French sheath on this side. Fortunately, the outside hospital was in our system, and so the CT scan that he had, I was able to look at that before he landed and make some quick measurements, which is nice to be able to have some idea of what you're getting into. And so we rapidly got access, pushed a large sheath in, contralateral small sheath, and usually I'll try and use IVUS and measure things, but we really didn't have time for this unstable patient. Here's his initial chest x-ray at the outside hospital. That chest on the left there filled up with a couple liters of blood in the interim on his way down. This was his CT scan, large mediastinal hematoma. So at the left common carotid artery there, he measures about 19 millimeters. Distal to the left subclavian artery, it measures kind of 27 across the transection. And then distally looks pretty small. Eyesight keeps getting worse. Looks like that's about 17 or 18. You can see the large hemothorax and the large mediastinal hematoma tracking along his aorta. You can see the measurements there in sagittal view. And so our measurements there are kind of 17, 18, 18 is what I got. So I figured based on his age and the sizes that we're seeing there that this would be a relatively small device. And so I had a 21 millimeter Gore C-tag device. And so we rapidly advanced this in and deployed it. It ended up having a bit of bird-beaking, as you can see there. I'm kind of halfway across the left subclavian. There was a huge distance between the left common carotid and the left subclavian, but as soon as we deployed the graft, fortunately he became much more stable. So we appeared to have a relatively good seal. The graft, like I said, landed halfway across the subclavian. His hemodynamics improved. We put a left chest tube in, got a couple liters of hemothorax out. He subsequently underwent a splenectomy, packing of his liver, and had all these other injuries that kept him in the ICU for quite a while. Most patients with a transection and or dissection, I would usually like to try and get some type of axial imaging on them during that hospitalization to know that we're not sending them out with some type of endoleak or concern. So finally his kidney function came back to reasonable values, and about 10 days later we rescanned him. And he's got a type 1A endoleak versus a possible type 2 retrograde leak from the left subclavian. So type 1 could have been from where the graft was bird-beaking. Maybe we didn't get the greatest seal there. and then it could also be retrograde from the left subclavian. And so when we ended up measuring him, his aorta was much larger at this point than when he initially got scanned in the CT scanner, and I think that played into a lot of it. So ultimately we did a carotid subclavian bypass on him, plugged his left common carotid artery. You can see the leak over the side here, hard to tell where it's coming from. And now we're measuring his distal aorta at 22 or so, where previously we had measured it at 17 or 18. And so we occluded his subclavian, carotid subclavian bypass, and I brought another larger endograft at this time to gain some more purchase and to get a better proximal and distal seal. And so at this point I had chosen a 26 Valiant graft at this point and put that inside of the C-tag. I think that's just what we had available on the shelf at that point. Kind of scary, some of the bare metal springs there, but everything seemed to seal, and we followed him for a couple years afterwards, and the graft sealed up and the leak went away. And so I think the lesson I learned in this case is that in a very severely hypotensive patient, I mean, ideally he probably shouldn't have even gone to the CT scanner in the first place, based on his hypotension of the outside facility, but obviously we have no control of that. But I think I definitely underestimated his true aortic diameter. So if I have a patient that comes in with an aortic transection that we're thinking about a thoracic endograft for, I'll usually run intravascular ultrasound up, and not infrequently will change the size of the graft because they may have been under-resuscitated when they had their initial imaging study. And then I probably should have gotten a better coverage over the left subclavian to get a good seal for this retrograde type 2 leak. So I don't know whether it was a retrograde type 2 or it was type 1. I treated both at the same time with extending the endograft and then the carotid subclavian bypass and covering his subclavian, or plugging his subclavian. The second case I have is a 60-year-old. Or any questions about that case, or anybody have done anything differently, John?
No. So what do you think you were leaking into? Was that a pseudoaneurysm? Was that a rupture space? Was that
I think that's
residual?
Essentially where the adventitia is kind of holding things on.
Okay. So basically where the previous rupture was. So, not a contained aneurysmal endoleak, like a pretty dangerous leak. Do you
pseudoaneurysm cavity there.
For transections, dissections, and aneurysmal pathology, do you have like a set algorithm for sizing in terms of percent oversizing? And have you changed that based on this case, seeing that you were undersized on your initial?
So both of those for either dissection or transection, you kind of do 10% or less oversizing. You don't want to oversize and tear the aorta further or cause a retrograde type A dissection. So usually it's supposed to be kind of 10% or so oversizing. In this situation, I think I got kind of faked out just because of his hypotension and a smallish aorta, especially in a young patient that really has significant distensibility of the aorta. Older patients with atherosclerotic disease, you're not going to get the same kind of differences in systole, diastole, and volume status, but definitely in the younger patients you see that.
Yeah, we use similar numbers to that as well, and in addition to that, I think in terms of your revascularization or covering the left subclavian, I think in most of the young trauma patients, they tolerate a left subclavian coverage no problem, and we only revascularize them kind of electively later if they come back with like left upper extremity claudication or something like that.
Yeah, great case, Marvin. Excellent result. A couple of questions for you. First, initially you started using, you used the Gore device, and then you used the Valiant Medtronic device. Can you just comment on your choice of graft there? And then would you use the newer generation, and how were you pacing? Do you ever try to pace as you deploy these to really try to land that proximal landing zone?
Yes.
Something that we've used more liberally recently.
Yeah, of course. So with most of the thoracic endografting cases I do from our experience of transcatheter valves use rapid ventricular pacing. It's so easy to turn the switch on and off and have the patient, their aorta not move, and to be able to land things more specifically. Obviously in the trauma setting, in a hypotensive guy like this, you don't have obviously the time or luxury to do that, and he's hypotensive enough for you that the graft hopefully shouldn't move as much. Sometimes with that device, you may not have the exact deployment strategy. I was worried about the distance, that there wasn't a whole lot of extra to gain between the left common carotid and the left subclavian. And so rather than kind of pull and pray. I wanted to have a little bit more control, and that's maybe why I chose that other device. But these days, for the most part, any of them are very good and conformable.
Did you give heparin?
I did not initially. Yeah, once we had the kind of the device deployed, then we gave heparin. Or actually, no, I did not, because he had a traumatic brain injury, so we did not with the subarachnoid hemorrhage. So basically, just flushed the sheaths continuously, hooked an IV line up to the bags, and just ran saline through those, and then tried to just go as fast as we can. And then I made sure at that point we had no time for perk closes or anything, so I had to cut down on the large sheath size there. And then I made sure that we back flush, retrograde flushed, made sure that there wasn't any clot in the leg.
I would have taken the same approach. No heparin, probably a Gore device. It deploys fast. One pig up there and be done and get out. Right. I think that's the right approach. So you can put these large endografts in people without heparin in the trauma setting, and the risk of thromboembolism is pretty low, and the stroke rate is pretty low.
Second case I have is just kind of really an anatomy case. This is a 60-year-old male, ASA class 4, pretty sick, comorbidities, 6.3 centimeter descending thoracic aneurysm with really crazy tortuosity of his descending thoracic aorta, some coronary disease, heart failure, COPD, previous CABG. And this is the tortuosity that we're kind of dealing with here. Let's see if that will play the next one. So what do you think about the tortuosity there? Is that doable with TEVAR?
It's there's tortuosity plus there's calcium. I'm assuming there's a lot of calcification. So oftentimes when there's tortuosity, you put a stiff wire in, the vessels can straighten out a little bit.
Right.
But in this case, there's also calcification, which is a little bit more concerning.
John, your thoughts?
Looks like you might need two stiff wires in this case to straighten that out, which is a technique you can use. I think my experiences with some of the newer low-profile devices, you can track a little bit better through stuff like this. But in first-generation devices, and even some of the stuff that's still on the market today, it can be challenging, and there are times when you can't get around it. You just can't get around it.
So the other option that we had for him was we had his right arm out, and you can get brachial access there, run a body floss wire from the arm all the way down, snare it, pull it out the groin, and that gives you a rail that you can then pull on both of the wires as you're trying to advance your device, and that'll help you get around. So we kind of had his arm out ready to do that, but we wanted to see exactly how tough it would be just using a Lunderquist alone. His vessels were 7 millimeters, so not the largest vessels, so we needed somewhat of a low-profile device. And then sometimes with those you lose trackability. And then with all this crazy tortuosity, how accurate were you going to be able to get some of the seal zones? And so we have a Lunderquist wire there. We're trying to get the device up, and it will not track into the transverse arch. And so we thought at this point, one option would have been to back the device out, come with a buddy wire from the right arm, make more of a rail. The other option we thought is maybe, we knew this was going to be a 3-piece device no matter what, is to see if we could land in that middle section and see if that would give us some more stability to allow us to then bank off of the graft in the middle there to put the more proximal piece. And that's kind of what we decided to do. So we deployed the middle portion device first, and then now having not that large aneurysm for the graft to bow into, we were able to then get the second device, which was now going to be our proximal piece, and it tracked around. And then we were able to extend down all the way to the celiac. So usually you deploy proximal to distal, stacking your devices inside of each other. So ultimately did fine, no neuro changes, ultimately went home on post-op day 6. And this is our completion CT, so very challenging anatomy. having to kind of bank this out. If I had to do this over again, I probably would have put a buddy wire in from above and tried to see if we could get that first piece in the usual configuration of getting that into the proximal landing zone first, rather than taking the risk of deploying it in the middle and not, we would have been kind of stuck at that point. I mean, I guess we could have rewired out to a brachial access at that point, but it seemed to work. And then extending down to the celiac. So we use the Navion device, which is one of the new Medtronic devices that's low profile, very trackable, very short nose cone. I've got another case, but I think in the interest of time, we'll skip over to your cases next. Yeah.